The first case was a 14-year-old girl. She was a patient who was known to have tuberous sclerosis. She wasn't, prior to this presentation, known to have any neurological symptoms as a result. She predominantly had skin lesions, but she was being screened annually with a MRI brain and spine, and the last scan had been about 9 months prior to this presentation. She presented to an emergency department with recent onset, fairly sudden, hadn't come on immediately, but had come on over the space of a few hours, of bilateral lower limb numbness, predominantly affecting the feet and the ankles, a little bit onto the lower leg. Examining her, there was no motor loss, it was a purely sensory loss. It was reproducible in the sense that if she was examined several times, she would say that the sensation was absent, but it didn't map to any particular dermatomes. And so I'm going to hand this one to you either by chat or by vocal to say what your thoughts are at this point. Stunned silence. Okay, I can't see any chat coming through at the minute, but I don't know if that's an issue with my login, so I will just continue talking. The differential I came up with at the time was clearly the most important thing to consider was whether this was a new tuberous sclerotic related spine or brain lesion. She had a known pre-existing medical condition which predisposed her to neurological lesions. The other possibility, of course, was that this was a completely random and separate neurological event. And then in the back of my mind, even from this first consultation, was the possibility of this being some sort of medically unexplained symptom. Because of the fact that the dermatomal distribution was quite weird, it didn't map to a standard thing you would expect. So because of this pre-existing neurological condition, the first thing we did was arrange a same-day MRI with gadolinium on the advice of our local paediatric neurologist who knew her very well. And I'm pleased to say that was normal. It showed no change from the previous scan about 9 months ago. But because the symptoms were there and persistent, we admitted her to the ward for further monitoring and to try and work out what was going on. And we're going to come back to this case a little bit later on. So the second case was a 13-year-old girl who was previously completely fit and well, no medical issues of any sort. And she presented with a single episode of collapse, but then persistent feeling of general weakness post-collapse. The collapse itself sounded pretty classically vasovagal. She'd complained of feeling lightheaded, had seen sparkly things in front of her eyes, no rotational symptoms, no focal neurology, and then she'd had what would best be described as a vasovagal syncope, and had come around fairly quickly with nothing to suggest any epileptiform event. But she just complained of feeling globally weak post-collapse and was having a bit of difficulty in mobilizing without some support. Examination was normal in the sense that there was no focal neurology. The only abnormality was a very mild postural BP drop, but not one which would prompt any concern. And there was no reproducible abnormal neurology findings. So, thoughts about this case? And thank you to the person who wrote B12 deficiency for the last case. Seizure, yeah, we thought about seizure, but it was very atypical in the sense that there was no pre-event warning, and she wasn't post-ictal afterwards. Eating, drinking normally, yep, she had been. She was normal BMI, she wasn't underweight. Vascular event, yep, that's a good call. Yep, baseline bloods. She wasn't from memory on her cycle at that point in time. I think she had a normal menstrual cycle and she wasn't related to that. So the differential was, we thought probably vasovagal secondary to postural hypertension was the most likely. We wondered about anxiety. Acute shock, well, her OBS were all completely normal apart from this very mild postural drop. And again, there was something about the presentation that just made us think, could this be medically unexplained symptoms? the weakness was a bit too non-specific. It didn't have a hard neurology feel to it or an ongoing cardiology feel to it. So we did an ECG, the basic bloods, as people have suggested in the comments, and they were all completely normal. There wasn't really a reason to admit her, but she got more weak when the possibility of discharge was mentioned, and her mother was unhappy with her being discharged home when she was having to support her to mobilise. And so again, she was admitted to the ward for further monitoring, and we'll come back to her. So our third case is an 11-year-old girl. She presented with a background of having had a very recent liver transplant. I'd actually seen her on the previous attendance when she'd come in with her acute onset fulminant autoimmune hepatitis, although we didn't realise at the time. She'd presented 6 weeks prior with very rapid onset of significant jaundice with no external cause. And I remember her INR was 13, and King's took her with immediate haste. And then sadly, it turned out she had an autoimmune hepatitis, but was lucky enough to be transplanted within about 2 weeks of being transferred to King's. Just so happened an organ came up. She'd actually been discharged from King's and been at home for about 2 weeks before she came into us. And she presented with severe abdominal pain. And this was a level of abdominal pain which wasn't responding to simple analgesia and which it was thought would require opiates to manage. Examination, she wasn't jaundiced. She had a generally tender abdomen all over. She had a large liver, which was consistent with it being recently transplanted, and there was a nice healing scar. It didn't look infected. There was nothing around it in terms of erythema. So thoughts about this case? Pain was all over. It was slightly more in the right upper quadrant, but actually it was pretty much everywhere. Rejection, yep, that was definitely something I was worried about. Obstruction, she was opening her bowels normally and passing flatus, and there was nothing to suggest any surgical obstruction. She wasn't vomiting. She was tolerating food and fluids. Stool habits were relatively normal. Okay, so we were worried about ischemia. Yeah, that was definitely something we were worried about. There was no ascites, and obs were all normal apart from a slight tachycardia. Stools were normal as well. So we were worried about either a post-op infection. She was only 4 weeks out of liver transplant at that point. We were also worried about the possibility of an acute organ rejection or some form of vascular event. The reason I put MUS on it was it wasn't clear at this point, in fairness, but we're going to talk about MUS. The thing that came up quite early on was that her level of pain was a little bit dependent on who was present with her. We obviously spoke to King's and did the armful of bloods that they requested, and fortunately they all came back as within the acceptable levels. They weren't normal, but they were normal for somebody who just had a liver transplanted. We managed to get an immediate urgent ultrasound scan, which excluded any thrombus and showed, as far as we could tell, a normal functioning liver in terms of there was no obvious obstruction, and the blood supply was all in place. There were no collections in the abdomen. There was nothing to explain why she was in such distress. And so again, she was admitted to the ward for further monitoring. So we're going to pause the cases there and then come back to them in a little bit and just think about what is MUS, or also known as PP. So there are multiple terms used to describe the same issue. The one that's most commonly used in the UK is probably medically unexplained symptoms. It's also known by some people as perplexing presentations, and increasingly in the literature, but more so overseas in the UK, it's known as bodily distress disorder. So these are all interchangeable terms. And sometimes you'll heard of it referred to as a functional disorder. The most important thing is there's no one pattern of symptoms. This can affect any organ system or more than one organ system. And the hallmark of MUS is that the symptoms that an individual describes are not fully explained by physical examination or investigation. What's really important, and something that occasionally gets lost in MUS, is that the symptoms the patient's experiencing are absolutely 100% real to them, They are frequently distressing and anxiety inducing, both to them, their family, and indeed the clinical team who treats them, because they can't explain why the child is having these symptoms. Apologies for the fire alarm in the background. Hopefully I won't have to evacuate mid-talk. What is it not? Well, it's absolutely not malingering. And that's very important to understand. People sometimes get labelled as faking their symptoms because we can't explain them medically. But actually, when you look at the literature on these young people, they are absolutely not malingering. It's not exactly the same as fabricated or induced illness, but we're going to come back and talk about the overlap a little bit later in the talk. In terms of the other things that sometimes get used, some people may have heard of somatoform disorders. It's a little bit pedantic, but if you're talking to mental health colleagues, this is distinct from MUS. The difference between MUS and somatoform disorders is that in somatoform disorders, something is physically wrong with you. So, for example, you have ankle pain, and what happens is the patient becomes psychologically fixated on that real symptom to the point where it becomes overwhelming. So it's an over-exaggeration of symptoms due to psychological fixation for a real condition, as opposed to MUS, where there isn't a clear explanation for the symptoms. Organic illness, well, the distressing thing is that if you look at the adult studies, about 4 to 10% of adults with presumed MUS do eventually turn out to have an organic diagnosis. And I think that's the other thing that's really important. When you're treating a possible MUS, you have to keep an open mind, because some of them will turn out eventually to have a rare or unsuspected disorder which does explain everything. So what do we know about MUS? Well, we don't know very much about MUS in children and young people specifically. There is quite a lot of research in adults, but not as much that's been explicitly done only on a pediatric population. Some studies suggest that up to 10% of children will get some medically unexplained symptoms at some point in their childhood. And that sounds a lot, but remember that a child who has a non-specific tummy pain, which is a well-recognized common presentation in general pediatrics, could potentially fall into the category of medically unexplained symptoms. In the literature, what you find is that most MUS is managed by self-care. Approximately 30% of adults with MUS will seek primary care support, and in fact, the majority of MUS is managed in primary care. Only 1% of adult patients with MUS will seek secondary care support. However, this 1% are often very frequent attenders of secondary care, frequent users of services, and frequent requesters of tests, and so they come to people's attention. It's possible the figures for this are slightly higher in children, but we don't have any published evidence that supports this. So what happens to people with MUS? So as you can see, although the majority of people with MUS, and this is adults again, do recover within 12 months, a not insignificant percentage will continue to have ongoing symptoms for over 12 months. And that is higher in things like neurology than it is in musculoskeletal. We don't have the figures for children, but we know it is possible for these children to go on with long-term symptoms. So going back to our cases, I'm going to link case 1 and 2 together at this point, because actually they came in very similar to each other at the same time in the same unit. Case 1 was reviewed by the paediatric neurology team, who knew her very well, and they were quite confident that the symptoms were not related to her TS. However, her symptoms deteriorated and she developed a new onset motor weakness affecting the lower limbs initially within about 24 to 48 hours of admission. The symptoms continued to progress and ascend, and over the next week she eventually lost all voluntary motor function below the neck, although she never lost control of her bowel and bladder habits and was able to tell us that she needed to use the toilet and was then assisted onto a commode. Case 2, who you remember was previously fit and well, was admitted coincidentally into the bed opposite case 1. And she mirrored all of the symptoms of case 1 until by the end of the second week, she had also lost all voluntary motor function, but not involuntary motor function, in exactly the same way that case 1 did. One of my learning from this point is if you ever have patients with MUS admitted to the ward, do not under any circumstances admit them into the same bay. Case 3 was on a different time in a different place. As we said, her pain continued, but it was noted to be incredibly variable and not related to analgesia or to movement or anything else, but predominantly related to when the mother was present. So when mum was present and in the room, she would scream in agony. If mum went out for any reason, then the nurses could get her to the point where she was talking quite calmly and freely. And yes, if you asked her if she was in pain, she would say she was in pain, but she wasn't screaming in agony the way she was. And as soon as mum walked back into the room, the screaming would start up again. The case was discussed again with the Kings the next day, and they were absolutely confident that this pain was unrelated to the liver transplant or the surgery. The bloods were repeated and hadn't changed. We did some additional imaging at King's request, and everything was reassuring. So having thought about how these cases progress, we're going to think about how you might manage similar cases in the emergency department, in the ward, and in the outpatient setting. And I again apologise for the ongoing fire alarm. I probably need to check I don't need to evacuate, so bear with me 1 second. Okay, so I'm going to have to evacuate mid-talk, which is a new one for me. I'm going to kind of keep talking. Oh, no, we've stopped. Thank God for that. Right, getting back to the talk. So, what can you do for these young people who you suspect may have MUS? Well, the good news is there is some guidance available. Currently available is the Royal College of Psychiatry's Medically Unexplained Symptoms in Children and Young People, which was published in August 2018. And that is freely available to Google, and I've linked it at the end of the talk in the resources slide at the end of this presentation. The Royal College of Paediatrics and Child Health has a new guideline which is due for publication very soon. I've confirmed with the college it is due out, but I don't have an actual date for publication at this point in time, but keep watching this space. There are some basic principles when dealing with children with possible MUS. The first thing is to really think about it early. So always have in the back of your mind that anyone presenting with unusual signs and symptoms could MUS be part of the differential. And it's important to be open with children, young people and their families about the possibility of MUS as soon as you consider it. And I would list it in the normal list of differentials in the same way I would be explaining the possible medical differentials. And the reason for that is the best way of managing these young people is by parallel investigation and management strategies. So it's not a case of we do all the medical things and then we hand you over to psychiatry and walk away. We talk from the very beginning about the importance of involving the mental health teams in managing young people with possible MUS. So this talk is obviously specifically around management in PTD as part of our PEM week. So probably the most important thing is to recognise that you might be dealing with a young person with MUS. And obviously ED is different to the ward and outpatients. You get to see people for a very short period of time, and it isn't always apparent at that early stage that this is clear MUS, but there are some things to look out for. So look out for frequent attenders. Frequent attenders with medical presentations, not so much with injuries. And another thing to look out for is attendances at multiple places, what's sometimes known as hospital shopping. So yes, they've been to your department 3 times, but actually mum also mentions that they've been to another 2 hospitals in the local area, and they've been seeing the GP, and maybe they've seen somebody in outpatients at another hospital, and maybe they've seen somebody privately. But essentially a pattern of people looking for an answer when they can't find one because people can't give them a straightforward answer. There's often quite a significant mismatch between the anxiety of the child and young person or their family and the medical concern. So a lot of these symptoms are not what we would consider red flag symptoms. They're ongoing and they're chronic and they're annoying, but they're not normally immediately worrying. But that isn't always mirrored by the family. And often the reason for that is by the time you're seeing them in the emergency department, they may well have seen several other people in several other places and been told there's nothing to worry about, but the symptoms are still present. And that leads on to the next thing, which is often you get to the end of the consultation and you find there is expressed or hidden dissatisfaction. So you're explaining to the family that everything's fine, there's nothing to worry about, and the looks you're getting clearly tell you that they're not happy about it. And what's important actually at that point is to explore with the family why they're not happy about it and what their concerns and expectations are. From a junior perspective, these cases can be quite complex, and I think the most important thing is if you think you're seeing anyone that might have MUS for these reasons or for some of the things we've talked about, then it's important to escalate early to a senior doctor to discuss the best way of managing them. So things you can do in the emergency department, it's to be open and non-judgmental. As we've talked about, it's really important to make it clear that MUS is not malingering or fabricating. It is dealing with symptoms that we cannot explain with a standard organic model. It's really important to acknowledge the child and young person family's distress. It's very tempting to say, oh, it's nothing to worry about, without actually acknowledging that it is disabling or painful for the young person. What you can do is be reassuring about the diagnoses you can exclude. And one of the phrases that I often use in the emergency department is to be reassuring about, we know there's nothing immediately dangerous or worrying. Clearly there's something that needs addressing, but it doesn't need to happen today, and we don't need to admit you to do it. And really what you're looking for is a pathway to ongoing care that preferably doesn't involve admission or returning to the emergency department. So this is where things like urgent review clinics, if you have access to them, are really important. Discussion with your inpatient colleagues, discussion with primary care sometimes. You do still need to provide a safety net, because remember, children will end up having organic symptoms. If you feel confident, then you can introduce a holistic body-mind link concept to the young person and their family. That's how to do that. Things not to do. So really, really importantly, not to minimize or ignore the symptoms. They are real to the patient. Also try not to over-investigate or admit if alternatives exist. These young people often have very weird and wonderful symptoms, and it is tempting to assume that something really serious is going on and just throw the entire laboratory at them, if not half of radiology. But actually all that's doing is reinforcing that there is something dangerous going on that we haven't detected yet. And that's reinforced by this concept of not focusing on getting a specific diagnosis as an alternative to MUS, but actually thinking of MUS as being the diagnosis. And this is where having somebody senior to have that conversation can be helpful. Some of these young people will end up getting admitted, and the 3 cases I've talked about all ended up getting admitted for different reasons. What's really important is as soon as there is a suspicion of MUS for an inpatient, then you need an earlier senior review, preferably a lead consultant, and they need to agree a few things. They need to come up with a list of appropriate and proportionate list of differentials, investigations, and specialty referrals. And there is a fine balance to be struck between not under-investigating, because we don't want to miss something, but also not over-investigating. So a sensible discussion at the beginning about which tests are appropriate, and then if they're all normal, that actually we don't need to do any more tests. It's really important that there is a lead clinician who will oversee case management and communication with children and young people and their families, because these cases, by their definition, are difficult to explain what's happening. And if different people tell the family different things, that just exacerbates the problem. And you want to link to your local CAMS or paediatric liaison team. And then, probably led by the senior, you want to know the discussion. And the first thing to do is actually explore what they think is going on. Do they have any theories about the symptoms? Do they have any belief systems around health or ill health? Do they have people in the family who've experienced something similar but different? It's not uncommon to discover, for example, at a relatively early stage in some of these medically unexplained symptoms, that a beloved relative has recently had a significant diagnosis of a similar organ system. And it's really important to introduce the concept of MUS or PP at an early stage if you think it's part of the differential. Don't surprise families with it at the end of a period of investigation. Introduce the concept of the mind-body link. And set out a plan with the children and young people about what tests you're going to do. And actually, it's good to be clear at the outset that you're doing these tests in the expectation that the tests will be normal. What families don't like is where they're told, well, we'll do this test, and then we say, oh, that's normal. Okay, well, we'll do another test. Oh, that's normal. And all we're reinforcing is we don't know what's going on. Actually, it is a positive thing. We think this is MUS. We are ruling out the other things. And once we've ruled them out, we don't need to do any more tests. And early joint working with CAMS and PLT is really helpful. And even if the family haven't yet bought into the diagnosis of MUS and PP, then talking to them about the importance of managing the uncertainty and the symptoms is an important part of engaging them with CAMHS or PLT. Outpatients, well, it's all a bit more relaxed. It's the same as inpatient care, but there's less urgency to manage it in a single consultation. It's still, however, important to induce the possible of a diagnosis at the beginning, not at the end. And where the facilities exist, then the best way of managing these is joint clinical consultations with somebody from PLT or CAMHS in the room with you and the patient, and joining together to manage the patient. And it just highlights the joint nature of this condition, the investigation. There's a question there, do you find that CAMHS and PLT are happy to be involved? So yes, I find they are often happy to be involved. My experience of working with them is absolutely, if I go to them as a clinician, I say, I think there's a really high likelihood this is MUS. We're going to do this test, and if they're normal, it's really looking like MUS, then they will definitely want to get involved. They'd rather know sooner rather than later. So that leads us on to CAMHS and PLT. So they like to be involved early. But even before the presence of your mental health colleagues, you as paediatricians can still explore some things with the family and the child and young person. It's really important to get a good chronology of the child's symptoms and to compare that with what was going on in the child's life at the same time. And one of the phrases that I learned from working with PLT colleagues was to consider the entrances and the exits into a young person's life. Who's come, who's left, who have they left? Have they moved school? Have they lost a close friend? Has a grandparent died? Has a parent split up? Has a new step parent arrived? Has a new step sibling arrived? These are all big events in children and young people's lives, and it's really important to have them documented in a chronology alongside the symptoms, because that's what allows you to start making links as to what might be potentially leading to MUS. Think about stresses at home, at school, with friends. Do explore the possibility of safeguarding concerns. So there isn't an intrinsic link with safeguarding and MUS, but there's an overlap. Some children who are being abused will turn out to present with MUS because they can't vocalize their concerns, and so they present with MUS. But not everybody is. But it's important to clarify and ask without the parents present, if at all possible, that are they safe? Is anyone hurting them? It doesn't have to be in school, at home. It could be in school. It could be over the internet. We still need to get documentary evidence. We've asked that. And you can use some screening tools. There's one called RCADS, which is a revised children anxiety and depression scale. And again, I put the link in the resources at the end of this talk. We talked about useful scripts, and this is taken from the RCP Psych guidance on managing MUS, and I'll just let you read the screen for a couple of minutes. So this is about how you introduce to a child and young person and their families the link between the mind and body, and the importance of involving CAMHS or PLT in the process early on, and not waiting until we've exhausted all of the possibilities before we get to this point. Other things that I've used with younger children, and MUS can present from very young, is to talk them through the impact of their emotions on their body. And so, for example, even somebody as young as 7 or 8 will understand the concept that if you're having the best day you can think of and you stub your toe, you probably won't be bothered if you stubbed your toe. But if you're having a really bad day and everything's gone wrong and you stub your toe, then it will feel really miserable, because it's another really miserable thing that's happened in a miserable day. And actually that's an approach that quite young children can begin to grasp, that how our bodies experience physical symptoms is absolutely influenced by our state of mind. And it's just a way of opening the people up to the concept of the link between the mind and the body. So we said we'd talk about MUS and FII. So fabricated induced illness is not the same, but there are some parallels, and sometimes there can be a little bit of blurring between them. In FII, explicitly the carer is the person responsible for the health-seeking behaviour. So in general, FII is seen in younger children, whereas in MUS, it's the individual themselves who's the prime reason for seeking help, and generally, therefore, they're a bit older. But it is true that young children who were subject to FII can transition to older young people with MUS. So if you've been brought up where your mother is consistently reinforcing this concept of you holding the sick role, from a very early age, then not surprisingly, just because you're the one making decisions, you probably are going to default to the same mindset around sick role that you might have had when you were younger. Just a reminder that FII is not a single thing, there's a spectrum, and the green to red is sort of the risk to the child from how the family approach FII. This is taken from Daniel Glazer's FII handbook, which the Royal College of Paediatrics has produced, which is also in the resources pack. So you started with the most benign form of FII, which is essentially over-anxious parents who are worried about their child's symptoms and will consult multiple people to try and work out what's going on and will hospital shop. And there's clear parallels here between this and what we're talking about with MUS. In general, this is amenable to reassurance, calm explanation, and careful managing. And there's very low risk to the young person in general, although occasionally children can end up over-investigated. The next type, type 2, is a bit more complex. This is where parents have fixed health beliefs around why their child or young person is ill. And this can occur as a result of a breakdown in communication between professionals, or maybe due to pre-existing health beliefs. It might be related to relatives or friends who've had similar issues. These are more challenging for professionals because the parents really hold their beliefs in a way that's not easily open to challenge. They are a set of fixed beliefs in the same way as a set of religious beliefs or political beliefs, and it's quite difficult sometimes. And again, this can definitely lead to a significant breakdown in working relationships between parents and carers, and therefore hospital shopping and re-investigation at the instigation of the parents. These are a bit more concerning, and they often do need a safeguarding input. Finally, we get to type 3, which is the most worrying. This is where the parents are actively fabricating and falsifying signs. And this is what we would have originally thought of as Munchausen's by proxy if you go back 20 years. This is the most worrying. It can absolutely lead to harm to the child. These are the parents who give their baby salt or administer insulin to their child, or definitely hurt them. You know, I know one child where the mother booked them into ED with a painful wrist, and then while they were waiting to be seen, took him into the toilet, wrapped his hand in a towel and hit him with a hammer to make sure that when he was seen, there was definitely something to be managed. So these are really worrying. And then type 4 is similar but different. This is where, so in type 3, the parent does not have a recognized mental health diagnosis, but is acting for unclear reasons. In type 4, the parent is suffering from an explicit psychiatric illness, normally some form of psychosis, where they have a delusional belief which leads them to harm the child. These are actually incredibly dangerous to children, but not because of active malice on the part of the parent. The parent is ill and needs help. But there are cases where parents have sadly murdered their children as a consequence of their absolute psychosis. And then again, FII, similar to talking about the fact that MUS, some of the children will turn out to have a true organic illness. Type 5 and FII in Daniel Glazer's classification was where actually the parent was right. There was something wrong with the child. And although they were labeled as having healthcare seeking behavior, actually they were correctly advocating for their child's needs. So how does this overlap with MUS? Well, in FII, safeguarding is based around either neglect, when the carer is not meeting the child or young person's medical needs. And this is really type 1 and type 2, where there's either over-anxious or fixed health beliefs. And from a safeguarding perspective, the parent is acting in what they perceive to be the child's best interests, but isn't necessarily acting in what we would perceive the child's best interests. When you get to the physical abuse or non-accidental injury, then that's the active fabrication. That's the type 3 and the type 4, where you actually got active harm happening to the child as a result of the FII. In MUS, it's much more complex because clearly the locus sits with the young person, not their carer. We've already talked about the fact that it's the child and young person who's experiencing these very real symptoms. However, it doesn't mean that there's no role for safeguarding in MUS. So we can still consider the possibility of neglect if the carer is not acting in the child or young person's best interest. So if they are supporting the young person in insisting on more tests or hospital shopping, or not really engaging with the mental health component, then that can be a reason to think about safeguarding. And as we'd said, there is a link with abuse as one cause of MUS. So let's go back to our cases. So case 1, we followed a fairly standard pattern of ongoing joint work with the general paediatric team, the paediatric neurology team, and physiotherapy and CAMS. The physiotherapist developed an active rehab plan, and that was really important to give them some structure and some targets and goals. Neurology reviewed them, and actually what was really good was they said to the family and to the young person, this is not to do with your tuberous sclerosis, it's not anything that requires a neurologist, and actually we're going to hand you back to the general team because they're the ones who need to manage you with CAMS. And that might feel like a bit of a cop-out, but actually it's really important in terms of reassuring the family subconsciously that this isn't something significant. And so what we entered into was a pattern of regular joint meetings with CAMS and the general paediatric team. And what came out when we started doing that chronology of events was there'd been a period of non-parental care which had preceded the onset of symptoms. So what had happened was mum had gone overseas for an extended holiday and had left the young person in the care of a family friend. And what we were able to get was that the patient was able to disclose that she felt very uncomfortable during that period, emotionally uncomfortable. She explicitly denied any form of physical or sexual abuse, and we asked her several times in many different ways. But she was able, with support from CAMS, to talk to mum about the feelings of stress without ever really disclosing the actual specific trigger. My gut feeling in this case was there was some form of emotional abusive event that went on that she didn't feel met a physical or sexual abuse, but was still distressing to that young person. And with her mother out of the country and no other support mechanisms, it became an internalized MUS. And following that disclosure, she actually made rapid progress, and her physiotherapy progressed quite rapidly, and she was actually able to be discharged home after approximately a 6-week stay, because it took a few weeks to get to this disclosure. Fully mobile, not having any active needs, and she just went back to her standard neuro follow-ups with no ongoing support from general paediatrics. Somebody's asked, is there any benefits coming up with the name of the young person? It helps if there is an explicit syndrome and management plan that goes with it. So for IBS, we can give quite a good way to manage it. But remember, sometimes labeling things doesn't actually take you any further forward. So you have to be careful, and I would take on a case-by-case basis and discuss with your seniors. Case 2, as you remember, was in the bed opposite case 1. She had a single review by the paediatric neurology team, and they agreed there was no organic neurology cause, and then they stepped away in the same way they had with case 1. Case 1, it had been relatively easy to reassure the family that this wasn't anything neurological. They were used to having MRI scans, and they believed and trusted the neurology team, and so when they told them everything was fine, they accepted that. Case 2 were quite different. They remained very concerned that we were missing an organic cause and weren't really confident in our initial management. And so we did actually agree to do an MRI brain and spine. There was no real medical indication for it. The neurologists were quite happy this wasn't going to be a neurological cause, but we felt that in terms of engaging the patient and her family, we had to reassure them to a point that wasn't over-investigating the young person, but would give them the ability to believe in us, to work with us. And so that's what we did. And actually we got better buy-in from the family once we'd done that MRI. Again, we introduced the joint working, and she made progress, but hers was much more variable. So case 1 had generally made slow but gradual improvement until we had the disclosure, and then she made rapid improvement. Case 2, she would take 2 steps forward and then 1 step back, and then 2 steps forward and 1 step back, and it was much more fluctuant pattern. And what became clear after the course of a couple of weeks, that actually these deteriorations were often triggered by a family visit. So she was in an adolescent ward, and the family didn't stay in the whole time, but would come in and visit. Parents were working, so they didn't necessarily visit the whole time. And the nursing staff became aware that actually her deteriorations were often triggered by these family visits. And in fact, there was then a critical episode where she went on her first episode of weekend leave, having made some progress and being able to mobilize with a frame, came back and had a really significant relapse. So she actually tried to hang herself in the bathroom, not in a particularly intentful way. It was more of a cry for help, that she didn't really tie the scarf around her neck terribly tightly. She made a lot of noise. People came in and found her immediately, but then she had a complete relapse and lost the use of her legs again. And so, having understood that for this young person, going home was not making things better, was making them worse, we actually worked with her to explore possible reasons. And what we found was that, sadly, she eventually disclosed a history of ongoing sexual abuse by her father. We clearly made a referral to CSC and police. Father denied the allegations. And the mother and the older sister sadly refused to believe the allegations and suggested the young person was fabricating them. However, police and social care had significant concerns that she was being abused, and in fact they felt that the older sister had probably been sexually abused and groomed as well, and that the reason the older sister was denying it was because it was just too caught up in her own trauma around it. So a plan was made for the patient to go to foster placement rather than return to the family home. And as soon as that plan was made, then actually we got really significant progress with physio. Once she knew she wasn't going back home, her symptoms began to resolve. And she was discharged with no medical symptoms into foster placement. And then the case continued down the safeguarding route, but required no further medical support. Harry's asked if an MRI found instanloma. It's a risk, but what you then have to do is to explain to the family that it's not the cause for their symptoms. And that's the risk in doing lots of investigations, and that's why we go back to having a senior person deciding what's relevant and proportionate rather than just blanketly, for example, doing an MRI whole body on everybody. Case 3, you remember, is our young person who was transplanted, who had severe abdominal pain. We had an open discussion with mum about the pain being different when mum was present and when she was absent, because from mum's perspective, all she ever saw was her child screaming in agony. And PLT worked with the patient and her family around her trauma around the whole diagnosis and sudden transplant. And there was a lot of unresolved trauma that she had. She'd been a completely fit and well child who had suddenly turned yellow one day and then been admitted to the hospital, then had a new liver, and then was on all these meds, and she just hadn't had time to process it. And actually, with some reasonably swift work, we were able to get her home at the end of the week with a much better understanding of her impact of her thoughts on her pain. She still suffered pain, but it wasn't anywhere near as severe as it had been. And actually, we got ongoing work with local PLT and CAMS, and her chronic pain didn't become ongoing chronic pain. Whereas I think if we hadn't recognised the early nature of the psychological impact of her transplant on this, it could well have become an ongoing chronic pain. So in general, what happens to MUS patients? Well, there's 3 possible outcomes. The majority get better, often without us being involved at all. So children with non-specific abdominal pain will often just get better. Some cases won't fully resolve, but they'll reach a stage where the young person can manage their symptoms so they don't impair function. And this might be talking about something like IBS, where they work a way to live their life without it causing them problems. About 1% of people presenting with MUS will have persistent symptoms. This is young people, not adults, where if you don't manage them carefully, they remain at risk of iatrogenic harm from their health-seeking behaviours. And what's important about this is that looking after these patients can be a real challenge for all the staff involved. Staff can feel frustrated because this isn't making sense to them, and we like to fix things as doctors and nurses and allied health professionals. So if it's not working for us, then we feel frustrated. We can feel inadequate or a sense of failure for exactly the same reasons, and actually that can often lead to anger when you put those 2 things together, particularly when people start to talk about malingering and fabrication and falsification. And it's really important that you don't transfer these feelings onto the young person or their family. And actually, it's really important to use opportunities like MDTs to allow staff to talk about their feelings safely and talk about their sense of frustration and anger when looking after these young people. Otherwise, it can come out in the consultations with the child and young person. The guide from the Royal College of Psychiatry has a really, really helpful top tips from a child and young person family's perspective, and that's what the next 2 slides are. So these are what families have said to medical staff. Don't make us feel guilty for being an inpatient. And this is what they're saying is it comes across. Be honest from the outset. Talk about the fact that MUS is a differential, and it means that we do know what's wrong with them. So MUS doesn't mean we've thrown our hands up and gone, we don't know. It means this is how we look after children who present with this sort of problem. Don't tell them the child is making it up or it's all in their head. I hope we wouldn't use those terms these days, but it does cause problems when it's clearly not just ill in their head, they're experiencing physical symptoms. And we talked about the importance of the whole chronology and the importance of the parent, the family, and their emotional state. Talk to them about the fact that their pain is really real. It's not that it's a fabricated pain. don't tell them there's nothing wrong with them and send them home with a child in a worse physical condition. This goes back to our managing these children in ED. We should try not to admit them, but sometimes you have to. And all 3 cases I presented ended up being admitted because they'd reached a stage where the family couldn't manage them at home. Very clearly the importance of communication, and this is particularly a problem for bigger hospitals with multiple specialities. These patients, if you're not careful, can get bounced from speciality to speciality to speciality, and nobody's holding the reins, and that's why it's really important to have a single overriding person in charge of the case. And as they said, make sure one doctor is in charge. So, any questions? Happy to take them on chat or take them orally if people want to unmute. So the next slide after this has got the resources on it, and that should be available when the talk is shared, or it'll be available on the recording on YouTube. So I left plenty of time for questions, and nobody has any. Don't know if it's my connection or if we're just not getting them. Harris has put up the feedback form, so you are still hearing me. What else can I say? These are challenging patients, and I think that's probably the most important thing to take away from it. One of the things I would say is watch out for a patient who you actively avoid, be that in the emergency department, you know, oh, I saw them the last 2 times, I don't want to go back and see them again, they're just painful, they say the same thing. Or for those of you doing inpatient work, the patient who literally reorganizes the ward around. So you might always start in bed 1, but just so happens this patient's in bed 1. And so instead, you start at the other end and work your way backwards because it's just too painful to go and see this patient. And if you've got patients like that who are making you feel frustrated, inadequate, annoyed, then actually start thinking about, should we be pushing them down the MUS pathway? Because that's a big link from my perspective between those 2 things. So a question about what are the alternatives to missing. So yes, absolutely, review clinics are an option. I think which clinic depends on your local setup, and it's very difficult to be didactic without knowing how your individual unit focuses. That's why an early discussion with a senior is the best way forward, because they'll know the best local policies. So in my hospital, I would get them into our urgent general pediatric review clinic rather than bringing them back to an ED review clinic. Because actually an ED review clinic isn't going to get them much further forward. What they're going to need is engagement with a general paediatrician who can manage the case and organise those appropriate and proportionate investigations and referrals if need be. Any other questions? I can see from the numbers that people are beginning to drift away. Do you find that the majority usually disclose something? So I would say the minority disclose specific abuse or trauma. It can be relatively minor things, and this is why the importance of entrance and exits is really interesting. So a different patient that had an 8-year-old who got persistent hiccups for no organic cause, and actually when you went back through the chronology, they'd started the day after she was told a beloved aunt was emigrating. Now that's not something you would expect to necessarily trigger MUS, but there was a very clear link, and actually when you were able to start talking to her about missing her aunt and how she would keep in touch, hiccups began to resolve. So it doesn't always have to be abuse or trauma. It's something that for the child or young person is relevant to them. I talked about the fact there's often a diagnosis. It's really common that, you know, somebody comes in with recurrent chest pain and you find that there are, you know, a grandparent or an aunt has had recent heart attack. That's really common. and there's a lot of anxiety. And of course, the problem is that often the anxiety is multi-generational. So you may well find the parent is anxious about their own parent who's just had a heart attack, and now their child is complaining of chest pain, and not surprisingly, the entire family is just caught up in this big anxious swirl. So other questions: what are your tips for safety netting if there are already red flag symptoms? So the RCP Psych guideline has a specific set of red flag symptoms that definitely merit a discussion with a senior. I didn't go them all on the slides because it would have taken about another 6 slides, but I can definitely direct you to look at that. And if you're getting red flag symptoms, then that should be discussed with your senior about how you safety net them. How do we untangle that? Overlap possibly, yeah. So we don't know. COVID's new. We won't find out for a while. I think it goes back to the thing about being open and honest and saying to the young person, this might be related to COVID. So chronic fatigue syndrome has an overlap with MUS, but is not exactly the same. And I think I would look at how you look at the two. Somebody's asked about out-of-hours conversations with family can be difficult for juniors and the best way to deal with them. So I go back to, you need to talk to a senior, and even out of hours, you'll have a senior you can talk to, and they should help you with a script to talk to the family. I think the important things are, it's reasonable to say, do you know what, your symptoms are not clearly one thing or another. This is a few of the things it might be, and I'm going to talk to my boss and think about what we can best do in terms of helping you get to the base of what is going on. If you've had experience with MUS, then it's perfectly reasonable to bring that into the discussion. I wouldn't do it for the first time without understanding a bit more about how it works, and this is definitely one to sit in with somebody more senior when having that talk to learn the best ways of having that conversation with family. It's easy to get it wrong and for the family to take away the concept that you're telling them their child is making it up, and you have to be very careful in how you phrase that. The scripts that we put up and the ones that are in the RCP Psych guidance are quite useful for that. Anything else from anyone? Okay, that's the resources page. So that's the medically unexplained symptoms in children and young people from the Royal College of Psychiatry. There's the fabricated induced illness by carers from the RCPCH, and the RCADS, which we referenced, the Revised Children's Anxiety and Depression Scale, is available online as well, and that's referenced in the Royal College of Psychiatry's guidance.